Dr. Shweta Bavari of Pharmacy Institute, Noida Institute of Engineering and Technology, Greater Noida. In this lecture session, I will be covering the topic Pathophysiology of Hematological Diseases. So, hematological diseases are basically pathological conditions that affect the blood or blood producing organs, basically the red bone marrow. So, there are various types of hematological diseases, and we'll be majorly focusing on iron deficiency anemia, megaloblastic anemia, sickle cell anemia, thalassemia, hereditary acquired anemia, hemophilia. So, before we begin, we should know what anemia is. So, anemia is basically reduction in the oxygen transporting capacity of the blood. This is because of the reduced RBC count in the circulation, reduced levels of RBCs in the blood circulation. Anemia may result due to either excessive blood loss from the body, which is also known as hemorrhagic anemia. Then there will be maybe excessive destruction of the RBCs, which results in hemolytic anemia, or due to decreased or impaired production of the RBCs from the red bone marrow. So, this is how anemia can occur. The general symptoms of anemia include fatigue because of lack of oxygen for ATP production, which is required for energy production. There is intolerance to cold in the patients or the people suffering from anemia due to lack of oxygen for heat production. Then the anemic people are generally, they have pale skin because the hemoglobin level in their body is reduced, which gives the pinkish tinge to their skin. So, they have a very pale skin, fair complexion and pale skin. Okay. And also beginning with the pathophysiology of iron deficiency anemia. As we all know that iron is a major component of hemoglobin. It forms the part of heme ring, and iron is the component in the hemoglobin that binds oxygen. So, it has oxygen carrying capacity. So, the distribution of iron in the body is that 65% of the iron in the body is present in hemoglobin. 15 to 20% of the iron is stored in liver, in spleen, bone marrow and skeletal muscles in the form of ferritin or hemosiderin. And this ferritin and hemosiderin, this storage forms are available again for the synthesis of hemoglobin. The remaining is stored in myoglobin and iron containing enzymes such as cytochrome P450 enzymes and catalase, and these storage forms of iron are not available for the production of hemoglobin. They cannot be utilized for the production of hemoglobin. Only ferritin and hemosiderin can be used. So, coming to the reasons why iron deficiency occurs in body. There can be reasons like low dietary intake. Now, people who resort to only vegetarian diet, the vegetables basically contain inorganic form of iron, and this inorganic form of iron is absorbed less in the body. Only 1 to 2% is absorbed when we consume vegetables. But when we resort to animal products like non-vegetarian diet, it contains heme form of iron and it has better absorption in our body. So, this can also result in iron deficiency. And then malabsorption due to gastrectomy. Gastrectomy is basically removal of certain portions of the stomach. So, when this surgical procedure is carried out, when certain portions of the stomach are removed, it may result in malabsorption of iron. Then there can be increased demands of iron in the body, like during pregnancy and during the child growth, during infancy. The iron demands increase because more RBCs need to be produced in the body. Then chronic blood loss such as in peptic ulcer, which is ulceration of the stomach and the intestine, hemorrhoids, which is also known as piles, then colonic cancers, the cancers of the intestine, or intestinal infestations with worms like tapeworm, roundworm and hookworms. These all conditions can result in chronic blood loss from the body. So, and this can again result in iron deficiency. So, regardless what the reason be for iron deficiency, when there is deficiency of iron in the body, the first thing that happens is the stores of iron, the ferritin and hemosiderin, these forms of iron are completely depleted from the body. They are completely utilized. Then after their utilization, when iron deficiency still persists, there is requirement of iron, the hemoglobin production reduces. and there is ineffective erythropoiesis. Ineffective erythropoiesis means the RBC production is ineffective. There are low hemoglobin levels. Low hemoglobin is being produced because iron is the major component of hemoglobin. Okay, so when there is deficiency of iron, there will be certainly reduced production of hemoglobin also. Now when there is very less quantity of hemoglobin, so the RBCs that are basically being produced, they are microcytic and hypochromic in nature. Microcytic means RBCs has a very small size, microcytic, small in size. Micro means small and cyto stands for cells, okay, small RBC cells, and they are hypochromic in nature means because hemoglobin is what gives RBCs their color, right? So when hemoglobin content is less, the RBCs are also pale in color. Okay, so moving ahead to the symptoms of the iron deficiency anemia. Generally, iron deficiency anemia is asymptomatic, but only in the severe cases you can see certain symptoms, like there would be excessive weakness, there will be thinning and spooning of the fingernails, the shape changes, and there is a characteristic symptom of severe forms of iron deficiency anemia, which is known as pica. This pica is basically the urge in these patients, in these anemic people, to eat clay or dirt. All right. Then moving ahead to pathophysiology of megaloblastic anemia. When we talk about megaloblastic anemia, in this form of anemia, the size of RBCs is comparatively large. Megaloblastic, they are large in size, RBCs. The two principal types of megaloblastic anemias are folate deficiency anemia, vitamin B12 deficiency anemia, which is also known as pernicious anemia. We need to keep this one important note in mind, that the folic acid and vitamin B12, these are two mandatory requirements. These are very much important for DNA synthesis. Okay, so when there is deficiency of folic acid and vitamin B12, DNA synthesis will reduce, and therefore there will be deficiency or there will be reduction in erythropoiesis also. Okay, erythropoiesis is production of RBCs. So in vitamin B12 deficiency anemia or pernicious anemia, basically there occurs the vitamin B12 deficiency occurs due to impaired absorption. Why vitamin B12 is not being absorbed into the body? This is because of the autoimmune disease. The autoimmune disease, a type of autoimmune disease which basically destructs the gastric parietal cells. When there is destruction of gastric parietal cells, there will be insufficient production of intrinsic factor, and this intrinsic factor is mandatory. It is required for the absorption of vitamin B12 in the GIT, in the gut. Okay, so this is what, because due to this autoimmune disease, vitamin B12 deficiency occur. There is impaired absorption of vitamin B12. Now when there is impaired absorption of vitamin B12, there is diminished DNA synthesis, because I told you vitamin B12 is indispensable, it is mandatory for the synthesis of DNA. Now when there is diminished DNA synthesis, DNA synthesis is occurring in a very slow rate. At that time there is delay in cell division. Now when there is delay in cell division, the RBCs keep on increasing in size. They keep on increasing in size, waiting for being divided, waiting for cell division. But because there is delay in DNA synthesis, so they keep on increasing in size, and that is why they appear macrocytic. Large RBCs are produced in vitamin B12 deficiency. Okay. Now these large size RBCs are released into the circulation, and they are very fragile in nature. Because they are very fragile in nature, they are prone to premature destruction. They will be destroyed very easily. So when the lifespan of RBCs is basically 120 days, but the lifespan of these megaloblastic RBCs or macrocytic RBCs is approximately 40 days. This is what results in anemia. Moving ahead, in folic acid deficiency anemia, deficiency of folate generally occurs due to either poor dietary intake or due to increased metabolic needs. As during pregnancy it occurs, the needs for folic acid are increased. So this folate deficiency results in the reduction in tetrahydrofolate levels in the body. Tetrahydrofolate is what? It is an active form of folic acid. Now this active form of folic acid is also mandatory for DNA synthesis. Okay, purine and thymidylate synthesis basically. So when there is folate deficiency in the body, it results in inadequate DNA synthesis. Now, when there is delay in the DNA synthesis, in this scenario also, the RBCs keep growing in size, the precursors of RBC keep growing in size. This results in macrocytic RBCs, which are released into the circulation, and because these are also prone to premature destruction, and this results in the anemic conditions. Now, the symptoms of folate deficiency anemia and vitamin B12 deficiency anemia, the symptoms are more or less same. They result in basically sore tongue and chillosis. What is chillosis? Basically cracking and pain at the side of the mouth, that is chillosis. Then in the severe cases of pernicious anemia or vitamin B12 deficiency anemia, there occurs dyspnea. Dyspnea means difficulty in breathing. Then there will be mild jaundice conditions. Mild jaundice conditions, we know that RBC, the product of RBC destruction is biliverdin, which is a green pigment. This biliverdin then converts into bilirubin, which is a yellow pigment, and which is a characteristic, the yellow pigmentation is also a characteristic of jaundice, all right. Then neurological changes such as numbness, tingling and burning in feet or hands, unsteadiness of the gait, means the walking style, the walking becomes unsteady, the steps the person keeps become unsteady. These symptoms also occur in the pernicious anemia. Moving ahead to the pathophysiology of sickle cell anemia. It is a type of hereditary disorder characterized by the presence of structurally abnormal hemoglobin. It occurs because of the mutation in gene encoding beta globin chain of hemoglobin. When there are mutations in the gene encoding for the beta globin chain of hemoglobin, now we know there are 2 alpha globin chains in hemoglobin and 2 beta globin chains in hemoglobin. We are focusing on the beta globin chains. The mutations are for beta globin chains. So what happens basically at the 6th position of the beta globin chain, okay, which is made up of a lot of amino acids, in the 6th position, the glutamic acid is replaced by valine. So it is not the normal hemoglobin anymore. The hemoglobin that is ultimately results, it has been given the name, that is hemoglobin S, HbS type of hemoglobin, which is abnormal. Now what is the abnormality in this hemoglobin? Basically, when it is carrying oxygen, it's normal. Okay, when it is carrying oxygen, it is normal. Now as soon as when the deoxygenation process occurs, means as soon as this hemoglobin delivers oxygen to any cell or a tissue, at that time its shape changes. This circular hemoglobin that gets converted into a rod shaped hemoglobin. Now imagine when the shape of the hemoglobin, which is inside a RBC, rounded disc shaped RBC, is rod shaped now, then the RBC also need to change its morphology. It becomes sickle shaped. Alright, so this initially is a reversible process. As soon as this hemoglobin will again get oxygenated, it will again acquire the circular shape. Then again, when during the deoxygenation process, it will acquire rod shape, and the RBCs will acquire a sickle shape again. So this process keeps on going until there occurs a membrane damage in the RBCs, and this results in what? The permanent sickle shape of RBCs. And this ultimately, just a minute, yes. So these dysfunctional sickle celled RBCs are recognized and removed by the phagocytic cells, the macrophages inside a body, and this results in chronic hemolytic anemia. Okay, there is hemolysis. These sickle shaped RBCs are recognized as malformed. They are malformed type of RBCs. So they are recognized by the macrophages, the phagocytes in our body, and they are destroyed. This results in excessive hemolysis inside the body. Now the symptoms of sickle cell anemia include, one is fatigue, weakness, then excessive hemolysis results in high levels of circulating bilirubin. I told you the end product of RBC destruction is what? It results in production of biliverdin, which is a green pigment, and this biliverdin then gets converted to bilirubin, which is a yellow pigment. This bilirubin ultimately accumulates in the gallbladder, which results in the formation of gallstones, and this condition is known as cholelithiasis. And ultimately this cholelithiasis also results in the inflammation of gallbladder, which is known as cholecystitis. Then there are also this we know that the RBCs have a sickle shape in cell anemia. Okay, this is not normal disc shape of RBCs. It is sickle celled. All right. So this sickle cell, when it is going through the blood vessels which have a large diameter, then it's fine. But when it enters into a microvascular system where there are narrow capillaries, there it results in obstruction. So wherever it will enter a very narrow capillary, it will result in an obstruction and will result in pain, because there will be what? When there is obstruction, there is obstruction to the blood flow to that particular tissue or the cell, and when there is obstruction to the blood flow, means the cell is not receiving any oxygen in that area, so it results in pain, all right, which has been termed as crisis. So this occurs very frequently in the sickle cell anemia. Also, this obstruction can occur in the coronary arteries of the heart, okay, and this can result in acute chest syndrome also. There can be pain in the chest, basically, which is occurring from the pain in heart. And then this obstruction can also occur in the blood vessels that are supplying to the brain cells, can result in oxygen deprivation in the brain cells and death of the brain cells, resulting in the condition named stroke also. So these are the common symptoms in sickle cell anemia. Now we move ahead to the pathophysiology of thalassemia. Thalassemia is a type of hereditary disorder characterized by a lack of or decreased synthesis of globin chains. Okay, so I already told that there are 2 alpha globin chains in hemoglobin and 2 beta globin chains in hemoglobin. All right. So when now there are 2 types of thalassemia. There is alpha thalassemia, in which the synthesis of alpha globin chains is reduced. Then there is beta thalassemia, in which the synthesis of beta globin chains is reduced. All right. Now this beta thalassemia is basically a more severe form. So in alpha thalassemia, as I told, there is a reduction in the synthesis of alpha globin chains, but the production of beta globin chains is normal. Now there is one, now when beta globin chains are being produced, so hemoglobin basically contains the tetramers of these beta globin chains now. So what happens, what the problem with these beta globin chains is basically that it has very high affinity for the oxygen molecules. These beta globin chains have very high affinity for oxygen molecules. So when the blood reaches any cell or tissue, and it now needs to, when this hemoglobin needs to supply oxygen to the cells or the tissue, it basically results in ineffective delivery of oxygen to the tissues. The oxygen delivery to the cells or the tissues is ineffective because oxygen is very tightly bound to the beta globin chains. This is alpha thalassemia. All right. Now in beta thalassemia, what happens? In beta thalassemia, there is reduced synthesis of the beta globin chains. All right. So when there is reduced synthesis of beta globin chains and alpha globin chains are being synthesized normally. All right. So when the hemoglobin will be formed, which is containing more of alpha globin chains, there is a problem with these alpha globin chains. They have a tendency to form insoluble aggregates and then accumulate. So when these insoluble aggregates, the cluster of these alpha globin chains is formed, all right, so this basically is deteriorating. It can damage the RBCs, all right, the cell membranes of the RBCs. Now when the cell membranes of the RBCs are damaged, it will ultimately result in hemolysis. Also, if the hemolysis doesn't naturally occurs, if the RBCs do not naturally are destructed, they will be marked for destruction by phagocytic cells, by the macrophages, because when there is a when the cell membranes have been lost, there is some permeability changes or there is some sort of destruction in the cell membranes of the RBCs, that means they are not appropriate and they will be marked for destruction by the phagocytic cells. Now we talk about the symptoms of thalassemia. So symptoms of thalassemia, of beta thalassemia are more severe because it is more hemolytic type. All right. So the symptoms that occur are like growth retardation right from birth of a child. All right. Because there is lot of RBC destruction, there is a lot of hemolysis. So this results in retarded growth in the children, all right, because there is reduced oxygen inside the body, so results in growth retardation. Also, there are skeletal deformities, there are bone deformities. How? What happens? Because there is excessive hemolysis, the RBCs are being destroyed in large number in thalassemia. So in order to match that, because there is lot of RBC destruction, so at the same rate there should be RBC production also. So large number of erythroid progenitor cells, when I use the term erythroid progenitor cells, I am saying the precursors for RBC production are produced in large amounts by the red bone marrow. Okay. So now where this red bone marrow is basically present? This red bone marrow is present in our long bones, it is basically present in our vertebrae, it is present in our spinal cord also. Okay, inside the vertebrae this red bone marrow is present. So when these large number of precursor RBC cells are being produced, they occupy a lot of space inside the vertebrae, they occupy a lot of space in the inside the long bones like the humerus, like the femur. So basically they interfere with the normal bone growth process, and thus they result in bone deformities, the skeletal deformities. Also, because it is a hemolytic type of anemia, so there will be repeated blood transfusion. In order for a person to survive, the person with thalassemia requires repeated blood transfusions, because hemolysis, destruction of RBCs is occurring inside the person's body, in the patient's body. So due to this repeated blood transfusions, what happens? There is an iron overload in the patient's body. When there is iron overload, this can result in cardiac failure. Okay, and this cardiac failure ultimately can result in death. So this is all about the hematological disorders in this lecture. Thank you.